Thank you so much, everyone, for joining us. We are trying a new platform here with Substance Talk with Sean, and we are in our third episode. So hopefully you guys had an opportunity to attend the previous episode, which delved into stimulants. Today, Sean will be exploring even deeper when it comes to crystal meth specifically. Sean, over to you.
Thanks, Dee. I've launched a poll, and I'm not sure whether people can see it or not. And you can send a reaction if you can, but it will be good if people can tick the choices that they believe are right in that poll. So if people have got access to the poll, if you can just select your answers on there. There's no necessary right answer or wrong answer. It's just really to get your ideas of it. And you can select multiple choices there. You don't have to select only one choice. So if you want to do that to get started, we are going to continue our discussion on methamphetamine today. And just a quick recap, methamphetamine is obviously a stimulant drug. The reason why we're talking about it is because we are beginning to see more and more methamphetamine coming into the Tshwane area. We're seeing more people using it. I see only 2 people have answered the poll at this stage, so if others could try and answer that, that would be great. Yes, so we're seeing more and more methamphetamine in the Tshwane area. And what we're seeing with the increase of methamphetamine is we're seeing a decrease in the use of crack cocaine. So previously, people who've been using niope or heroin have tended to use a stimulant alongside it, and that stimulant often is crack cocaine in the past. And we're seeing less and less crack cocaine and more methamphetamine, which is interesting on one level, but a lot of people will ask the question, why is that? And there are a lot of reasons why. Crack cocaine is a very fast and short-acting drug. It's smoked like methamphetamine usually is, and it's a free-base form of cocaine. So it's not like powdered cocaine. It's a concentrated form, and it has a very short half-life. In other words, it doesn't last very long in your body. And so what tends to happen is people take the crack to feel a bit more awake, but what that leaves them feeling is that they want more crack. So all that crack really does is it makes you want more crack. It doesn't really fulfill any meaningful purpose in a person's life. And it's very expensive as well. It's way more expensive than other drugs in the South African context, and so you need more money for it. The reason why people would move across to methamphetamine from crack is because the methamphetamine has a longer half-life. It's a very long half-life, in fact. It's as much as 12 to 24 hours, depending on the individual. And the reason why people use it is because it's got a longer effect. It doesn't put you into that cycle of just wanting more all the time. And it supplies a very definite need for a lot of people. Now, the main ingredient in methamphetamine, the main sort of cause of action, or what it does to the body, is release dopamine. It releases, got 5 mechanisms for releasing dopamine into the body. So you're getting a lot of dopamine sitting in the synapses in the brain. And people often misinterpret dopamine as being about wanting, about liking, and it's not. Dopamine is not about pleasure. It's not about liking things. It's about wanting things. It's a motivational neurotransmitter. It's something that encourages you to do something. It makes you feel active. So that's one of the big things about it, is it releases dopamine. The other thing that dopamine can do is increase focus for some people, in particular people with ADHD and those kinds of problems. It increases focus. And so you've got people who are using heroin in the Tshwane setting, in the cases that we're talking about, who are feeling very amotivational. They are a sort of depressant or narcotic, which is making them feel sometimes quite sleepy, although comfortable. And now they want to do something like go and get some money so that they can get their drugs, or go and collect scrap, or participate in whichever activity they participate in to raise their money. And so they need some motivation. And so methamphetamine fills a very good purpose for them in that it makes them feel as if they're active in doing something and motivated to do something. And we have a number of jokes around methamphetamine in the settings that I've worked in the Western Cape in particular. We say things like people spend the whole day sorting out their sock drawer. That's obviously if they're privileged enough to have a house and a sock drawer, which many people don't have. They will resort it and sort it again. People will resort their toolboxes over and again. And we have another saying, which is they fix things broken. So they'll take things which are working, like in the old days a video machine, or these days a computer, and they will take it apart because they're motivated and they focus on doing something. And often it will end up in a worse state than it started. So those are kind of stereotypical kind of jokes that are made. The other joke that everybody says is the great advantage of taking methamphetamine is there are only 2 more sleeps until Christmas. So it heightens one's motivation, it heightens one's engagement with things, it helps focus, and it cuts down on sleep. In fact, one of the reasons why it was sought as a medical drug early on is to, and in fact even today, is to stop narcolepsy. And narcolepsy is when people just fall asleep during the day and they're not able to do much about it. And methamphetamine is very helpful in keeping people awake. We also know that in the last few wars that we've seen around the world, from the Second World War onwards, even earlier, methamphetamine was used by soldiers and is used by soldiers to keep awake. The American Navy used it for extended flight missions to keep their pilots awake and active. And we see it, we saw it a lot in kamikaze pilots in the Second World War. That's Japanese fighter pilots who used to use their planes as bombs and fly them into sides of ships. Obviously, chance of surviving, that's about 0. And methamphetamine helped lower their inhibitions to some degree and also made them very motivated for that. We've also seen rumors of very high-powered people using methamphetamine. It's rumored that even American President JFK used it, and that the Adolf Hitler also used it as well. Of course, just because Adolf Hitler used it doesn't mean that it caused Adolf Hitler to be who he is. Methamphetamine simply kept people awake and conscious enough and stopped them from sleeping so they could continue with very, very busy days. So methamphetamine, let's end the poll now quickly. If we have a look at it, and we can share the results. I hope you've seen them on screen. A lot of people think it's a worse drug than heroin. It's the cause of crime in communities, some people thought. Creates only harm for the user, and the harm depends on the drug setting. Well, methamphetamine can have significant harmful effects on an individual, in particular on their mental health if they're taking large quantities of it. But it's not only harm that it creates for the user, because otherwise people wouldn't use it. We have this misconception that people use drugs despite the harms, but the reason people use drugs is for the benefits. And so if there were no benefits, they wouldn't use the drugs. You don't become addicted instantly, and therefore you wouldn't just use it because you have an addiction. You would use it because it has some form of benefit and continues to have some benefit for most people. Remember, at smaller doses, which we discussed last week, methamphetamine has been shown to improve cognitive abilities in people on certain testing, and in fact, in some cases, lower inhibitions and impulsivity, increase impulsivity, lower impulsivity in some cases. Even I'm getting confused with this. Whereas the typical narrative is that it reduces inhibitions and increases impulsivity. So that's not with all people that it can have the effect of reducing impulsivity. It just tends to be amongst people who've got ADHD, who are very impulsive, and the addition of extra dopamine into their system helps them concentrate and think about things a bit more than they might normally think about them. Right. So What do we see typically when people present with methamphetamine? What we see is we see a lot of people who are hyperactive at times, who are feeling quite anhedonic when they're not on it. In other words, they're feeling quite depressed when they're on it, and their cycle of use tends to be a binge collapse cycle of use. What that means is they will typically use for about 2 or 3 days. They won't sleep at all during that time, and then suddenly they will collapse and go to sleep and sleep for 2 days, eat a lot, and then start the cycle over again. This tends to be more obvious amongst people who are only using methamphetamine rather than people who are using methamphetamine and heroin or niobe at the same time. For the people who've got the primary drug of niobe, what we tend to see is they use smaller amounts of methamphetamine to help wake them up and to overcome the sleepiness and the depressant effects of the heroin so that they can go out and be motivated to get more work, to get more money for their drugs of choice. In other settings where we've got people taking low doses of methamphetamine, a lot of people function really well on it, but that's the exception rather than the rule in an environment where drug use is highly stigmatized and criminalized. So I'm going to talk about specifically, I want to get practical now on how do you deal with people who are on methamphetamine and maybe want to moderate their drug use. So here's some news that very few people will tell you, that a significant majority of people are able to quit drugs, and that's all drugs, or moderate their drug use levels, and they're able to do that without any form of treatment. It's about 73% of people in population size studies. Now, these population size studies are not done in the South African context. It's very important to note that they're done in the American context, which means that people have far more external support. They have far more access to job opportunities, to work. In fact, in America, at the moment, the majority of people, sorry, not the majority, but a lot of people are giving up their jobs and taking on different jobs because there's so many jobs available in the market. Certainly, that's not the case in South Africa. So we've got to treat these figures with a little bit of suspicion and really have a look at them. But it's important to note that given the right set of circumstances, or a better set of circumstances, up to 73% of people will resolve their substance use issues without any form of treatment whatsoever. So the first message is that it is possible. There's not a single well-controlled study to show that a 28 model of rehab that's typical will produce any better results than spontaneous remission from drug use. And we also know that outpatient services show better results than inpatient services, especially when delivered over time. Typically what type of intervention we use for people who are on methamphetamine is things like CBT, which is cognitive behavioral therapy, which is a specific kind of therapy that looks at the way people think about things. Group work, your LOM groups in particular, which are open-ended groups where people can discuss issues that come up in their life. And interestingly enough, those discussions don't have to be about the drug use. Contingency management has also been shown to work with methamphetamine. Now, what contingency management is when people are abstinent from the drug, they get a reward, and that's often a financial reward. So, for example, in the United States, they've used a lot of contingency management where people come in and there's a fishbowl in the middle of the group. And if they're abstinent and they measure abstinence using urine testing, then the individual can take a voucher out of the fishbowl and it's got a reward on it or no reward on it. It's totally random. And those are usually fairly small rewards, like maybe a $5 voucher. What's really interesting to note is that the people that tend to save up their rewards, maybe they save all their $5 vouchers so they've got a $30 voucher, don't do as well as people who exchange their vouchers immediately, which is interesting. Often people would think it would be the opposite, but the reason is that the voucher and the exchanging of the voucher gives a person a bit of a dopamine spike, because you are motivated then to buy the actual recognition of the reward. And so we can extrapolate this and we can look at what is meaningful to people in general. And relationships are meaningful to people, and compliments are meaningful to people. So we don't actually even need to have a financial reward. a form of contingency management is to praise people when they're doing well. We also, in our settings, don't really use drug testing, which is, I believe, a good thing. We can just work with the person. Is their behavior improving? Are they meeting the objectives that they set? And therefore, if we reward them, they actually respond well to the reward and they feel encouraged, and will then move on to try something maybe a little bit more challenging for them, such as a few more days of abstinence or maybe moderating their drug use. Confrontational processes definitely do not work. There's no evidence for them. And in future sessions, we will just be discussing motivational interviewing, which will give us quite a strong framework on which to engage with people in a non-confrontational way. So how do we speak to somebody who's come to you, they're sitting down in front of you and they say they want to change the way that they use methamphetamine? The first thing you do is encourage them and say to them, you can change and this is possible. The changes that you want are not something that you can't do. And often people have heard the message that once an addict, always an addict. It's simply not true. There are lots of people who resolve their addictions either through moderation or by stopping the drug they use. Next thing to say to them is, if you want to moderate your drug use or stop your drug use, now is the time. It's not the time when things are perfect, because things are never going to be perfect. So you start making the changes from today, even if there are minuscule changes. You can maybe take 3 less hits a day of methamphetamine, maybe 1 less hit a day. Maybe you can just limit your using to before 3 o'clock in the afternoon so you can get some sleep, right? So very simple things, but today's the day to start. And people need to decide, and they don't have to decide all at once. Do they want to stop totally? Do they want to reduce their use? Do they reluctantly want to stop to make somebody else happy, perhaps? Because these are all very important things. So the next thing is to ask people why they actually use methamphetamine. It's not acceptable to answer because I'm addicted. That's not very helpful to anybody. We don't even know how to define addiction properly. So if people say I use just because I'm addicted, interrogate that even further. The way you would interrogate that is to say, when do you use the drug? When do you feel the craving is the strongest? What is it that the drug gives you? And then you do a change analysis, which is you ask them, what are the advantages of stopping drug use, totally? What are the disadvantages of stopping drug use? What are the advantages of continuing drug use? And what are the disadvantages of not continuing drug use? Now, that sounds like 4 very similar questions, but they're actually slightly different. And we see people come up with different answers for those things. And some people will say, absolutely, I see a lot more advantages in stopping use or moderating my use. And there are 1 or 2 people that might even see advantages in continuing their use. It just means that they're not ready for total abstinence. It doesn't mean they can't reduce the harms. It doesn't mean that they will never come back. It's just about giving them an idea of their state of change and what the advantage of, or their stage of change and the advantage or disadvantage of using their drugs is, so that you've got something to work with. Often for people to stop immediately is not the safest idea for them or the best idea for them unless they're really committed to it. And when I say safest, there is some evidence to show that rapid cessation of methamphetamine use causes an inflammation of white brain matter due to sort of some kind of almost assault on that particular area of the brain. That's not conclusive evidence. It is preliminary evidence at this stage. But you often find that people, when they stop suddenly from methamphetamine, they have a mental fog, they have a cloudiness around them, and that might be related to those brain changes. But if somebody definitely is committed to stopping, don't discourage them from that. But the vast majority of people will do much better through an incremental decrease in drug use. I saw something pop up on the chat about that a moment ago. So one of the ways of doing it is just by, first of all, saying, I will not use after 4 o'clock in the afternoon or 3 o'clock in the afternoon. Remember, it's got a long half-life. We want people to sleep. Then we'll say, okay, I'll reduce my doses. Each time I take it, I will only have 1 hit. I won't have 2 or 3 hits, or I'll only spend so much on it. And then slowly bring it down and maybe eventually end up with just using once in the morning. And then slowly people can wean themselves off it and find other ways of giving them some level of motivation in life. Of course, this is much easier to do when you've got strong support. And the support that most of the people that we see will get comes from group work or from visiting the site itself. So I see there are some questions coming through. I'll get to those in 1 minute. I just want to finish this quick section here, which we're almost done with. So what we've got so far is we've got a belief in the person's ability to resolve their drug use. We've got don't wait until things are perfect. Decide what you really want to do. Do you want to totally stop, reduce use, or are you just trying to keep somebody else happy? Obviously, if you're trying to keep somebody else happy, the motivation is less, but it doesn't mean that there isn't a validity in that. Why do you use meth use? Why do you use meth? What are the benefits of it? What are the disadvantages of it? What are the benefits of stopping? What are the disadvantages of stopping? What are the advantages of not stopping? And what are the disadvantages of not stopping? The things we ask each other. Don't necessarily stop immediately if you don't feel you're up to it. Down titrate your dose slowly. Set yourself small goals on a daily basis. I would also strongly suggest, it depends how you frame this, mindfulness as a practice. Not everybody has access to that, but in group work, we should seriously consider it. And there's a very good app online called Mindfulness Coach. I will organize to get the exact URL to you, and I'll explain to you how I'll do that in a minute. But Mindfulness Coach is a free app that's available and works on the majority of cell phones. It's actually developed by the Veterans Association in the United States for PTSD, but it's a very clear and simple way of getting into mindfulness. Unfortunately, there's only an English version, and also we understand that people with different education levels might struggle with some of these things, but certainly in group work, we should be doing it. The other thing we encourage people to do is each time they're about to have a hit of methamphetamine is to ask themselves, will this make things worse in this particular moment? Is it going to increase harms? Is it going to cause more problems right now? Yes or no? If the answer is no, don't want to take it because it's going to cause the following problems, try not to take it, or try and delay it, or take less than you were going to take. But think about the purpose of taking the drug in that moment. Yes or no? And hold yourself accountable to that. But don't beat yourself up if you say it's not a good idea to take it now, but you still end up doing it. But at least you're thinking about it. Encourage people to think about their drug use, because the only goal we should have is most of the time we should be encouraging people to make informed, conscious decisions about the how, when, where, how much to use a drug or not to use a drug. That is what the objective is. It's not to stop people from using drugs because we don't have power over that. It's not to force people to stop using drugs because that's coercive and probably not helpful. But what we should be doing is encouraging them and assisting them and empowering them to make some conscious level decisions around their drug use, and to, more often than not, make decisions that are the decisions that they really would like to make. The other thing is encourage them to own their use. And what I mean by that is there are valid reasons why they use the drugs, and they should acknowledge that. They shouldn't say, oh, well, I don't use, or I only use occasionally, and make excuses for it. Own it and work out the reasons why they're using it, because that makes it much easier for people to start thinking about these things in a non-judgmental and positive way. My final point is just to talk very briefly about how to reduce risk. And there are some very clear rules for this. And I'll post these in the chat as well. Use the minimum amount of dose to get the effect you want. Meth has a long half-life, so you don't need to use every 30 or 40 minutes like you do with cocaine or crack cocaine. High doses will eventually lead to excessive amounts of dopamine, which can become neurotoxic. So limit your dose. If you inject, never share needles and sterilize them if you must reuse your own needles. Eat at least once a day. Yogurt and things like that are good. Lie down in a dark room for at least 4 hours per day, even if you don't sleep. Just lie down. That's very, very important because that enables people to avoid the typical problems of psychosis that they often suffer. And it helps people just get some peace and rest, and that, which is very important in avoiding psychosis. So I'm posting these tips into the chat box now. I'm going to look at the questions and what questions there are. So Dr. Bura has asked, with contingency management, do the effects of the rewarding stop? Does it retain the effects? The answer to that question is, in some studies, they've shown that repeated contingency management can help people in a longer term, and I'm talking about 3 to 6 month basis. But usually people need continuous rewards in order to stay stopped. But what it does do, if you can maintain the rewards, and I'm talking even about social rewards, I'm not just talking about monetary rewards, I'm talking about rewards like just acknowledging them and making them feel heard. Then what they would do is we would look at, they would find other ways of boosting their dopamine levels. And then the return to methamphetamine is not necessarily guaranteed or something that isn't sustained. But we need to look and see what other drugs are they using concurrently, or what other activities are they engaging in. So often we will see in certain populations, and your population maybe not, but certainly in middle class populations who have got access to a lot of economic privilege and resources, they can access gyms, for example. And so what we see is people obsessively training in the gym when they cut out the methamphetamine use to the point of even harming themselves. So we just need to be wary of those kinds of things. Obviously, a so-called obsession with exercise is a lot healthier for somebody than an obsession with a particular drug, but it too can cause harm. So to answer your question directly, the changes are not necessarily sustained. You need to have constant small rewards for individuals while they're going through the change process. But once the change is stuck within the individual, once they've learned new ways of coping, then those changes tend to be sustained. There was a very interesting study done several years ago, which showed that people who had been in resolution of their drug use or drug dependence for 3 years and more were less likely to become addicted to a new drug than the general population, which goes counter to the narrative of once an addict, always an addict. And the reason for that they worked out was because people had learned better coping mechanisms in life. And so I think that's quite an important thing and lesson to learn. Would rapid cessation of methamphetamine use not be related to dose? Yes, it would be. If somebody's on a very high dose, it might be more difficult for them rapidly to cut down on their methamphetamine. But if they're using smaller doses, they can cut down immediately and stop using immediately. I'm not sure if I'm answering that question correctly, if I've understood it correctly, Dr. Bura. All right, so at this stage, I would encourage anybody who's got any questions to please ask the questions in the question box or in the chat room. If you see any things in the chat room or any questions, please point them out to me. But in particular, if there are any questions there from anybody, and then also just calling presentations here to see if there's anything from here that we need to pull up. But what I'm interested in particular is, are you seeing a lot of psychosis amongst methamphetamine users? I see there is a hand up here. Is that you, Dimakatsu, asking?
Yes, there's a question also from Urvisha.
Yeah.
It's in the chat box. It states that In our settings, many will say they use meth to increase motivation, energy for hustling. Heroin
Yes.
slows them down and meth makes them productive. In an economy where 35% of people are unemployed, it's difficult to convince people otherwise. That was a comment.
Yeah, so that's a very good point. And that's why, one of the things that frustrates me is that there's this increased focus just on treating people who use drugs without offering alternatives. And really, we would cut our drug use and our problematic drug use in particular significantly if we were able to increase employment opportunities. So that's one of the big issues that I'm constantly battling. When people have no things or reason to get out of bed every morning, that's a major problem. If they have no employment opportunities, there's an inbuilt thing into people that we want to work in some way. We want to be making a meaningful contribution to the world. And if there's no opportunity for that, drugs make a very attractive substitute for people. It doesn't mean all people who don't get the opportunity of working will turn to drugs, but they invariably will turn to something. And that's why even when people aren't paid, if you find work for them to do, they find meaning and purpose in that, and then feel more motivated to cut down their drug use. I'm not saying you should get people to work without pay. I'm just saying that an activity that people find meaningful to them apart from drug use does definitely help reduce the drug use. If there are no other questions, what I could do is I could also talk about a specific case study we had, which was a 28-year-old young male on meth on weekends for 4 years. He has a job in construction. He suffers from a sexual dysfunction. His mother wanted him to enter into treatment. She says he's spending too much money on methamphetamine recently. He misses his Friday afternoon appointments with his counselor. And when he's at the appointments with the counselor, he appears to get pretty agitated. He's got a history of untreated ADHD. So what would you do with somebody like this? And in particular, if he doesn't really want to stop using the meth as much. So the appointments on a Friday afternoon where he's agitated, the only time that he could make the appointment, and this is an actual case study, by the way, it's not something that was made up, somebody that I saw in the Hope House setting a few years ago. And so what we did was we reduced the duration of his appointments, because on a Friday afternoon, he wanted to go jolling with all his friends, he wanted to go drinking, he wanted to party a bit and that. And also, he had limited time once he got home to get ready and that. So we reduced the duration of his appointments rather than cancelling the appointments, because we wanted to keep contacted with him. We worked on him in establishing the reason for his using, which was really about enhancing his sexual ability with his girlfriend, because methamphetamine enables people to last far longer sexually, which is one of the reasons why it carries risk for HIV. So that was another issue. He also had this severe ADHD and felt he couldn't concentrate on anything, and as though life was passing him by without ever achieving anything. He only used on weekends because he didn't want to put himself at risk at work, which was a very good sign that there was possibility of moderating his behavior even further. And the biggest problem he was having with his methamphetamine use was managing the finances. He was finding his tolerance building up and using more and more and more. And that was possibly about to spill over into the weed use. So we discussed that. In the end of the day, he went and got some treatment for his ADHD, and that actually meant that and also some blood pressure treatment, which the methamphetamine wasn't helping as well, which helped him resolve some of his issues with his concentration in that. And he started exercising more as well, which, interestingly enough, helped resolve some of his sexual issues. And over a period of about 5 or 6 months, he stopped using methamphetamine totally. And last time I saw him, he wasn't using methamphetamine. So it wasn't a confrontational approach. It was a person-specific approach that kept contact with him. We emphasized dose. We emphasized the potential harms to his finances. we treated his untreated underlying ADHD, and we spoke about the reasons why he used and tried to resolve those reasons, which resulted in him cutting down and stopping using. Sorry, there's a phone ringing here, and I'm not sure where it is, so just let me try and stop it quickly. Sorry about that. My phone, it's normally other people's phone that rings, but in this case, it was my phone. I'm just putting it on Do Not Disturb. Right, I don't know if there are any other specific questions that you've got on this question. We could also talk about dealing with psychosis if that's something that's of interest to people in the last 10 minutes. I'm also patently aware that you're probably sick and tired of hearing my voice. And the reason that we've kept it just to me for the first 3 sessions is for a couple of reasons. First of all, is because we've been testing out different platforms and testing out different formats, and also inviting various speakers to join us. We are moving on to motivational interviewing in our next few sessions, and we have some nice surprises there for you in terms of who will be talking in those. We will announce those later on in the week. And the other thing that I alluded to earlier on is that we are busy setting up a website at the moment, which should be up and operational before the next session. And a lot of the materials and resources that you might need or want to use from these sessions will be going onto the website. And as I say, that will be operational before the next motivational interviewing session. And you'll be able to refer to the website to see, to get materials off it, and also to do some pre-reading if you want to do pre-reading as well. Are there any more questions, or does anybody else want to discuss anything in particular?
There are no questions at the moment, but
Okay,
also
so
to encourage everyone to please, any specific topic that you'd like us to address in the future, please share on the chat.
Okay, and then we've got, I think we have got one more poll as well. Let me just see. Okay, for some reason it's not, yes, there is one. So here's one which I'd like people to just fill in quickly now while we're here. Can you see the poll? Is it shared?
Yes.
I'm presuming so, okay.
So the poll states, what is the most important for reducing harm? So please take some few seconds to respond to that.
So obviously choice 5 shouldn't be there because it just says choice 5. And it is allowing multiple options as well. Guys, I see somebody's taking the easy option, which is choice 5. All right. Just while we're doing this, quick note on psychosis. When people present with psychosis, people often panic. I've seen that often when people really get quite stressed about it. We will make available to you a guideline on dealing with psychosis for non-clinicians. But the most important thing is just to try and keep people calm and not confront them, or to not challenge them too much in their psychosis, and to really get somebody who's experienced in it maybe to discuss with them. Right, we've had 17 people answer the poll so far, so I'm going to end it now quickly and share the results. Yes, I would probably say that dose is the most important thing. I would tend to agree with that. Sleep is very important as well, and hydration and nutrition are also important, but I would say if you had to choose one, dose would be the most important one. One thing about hydration, there's often an overemphasis on hydration. So we must be careful, because for example, people who use MDMA, which has got an amphetamine component to it, and they're out dancing or at these music festivals and that, the message was always drink lots of water, and people would end up drinking so much water that they would die from water toxicity. And that's actually a thing. That's when we saw a lot of runners at the Comrades Marathon being encouraged to overdrink. We saw a lot more deaths of runners in ultra marathons and that from overhydration, because it dilutes all the I think it's the salts in that in our blood and that, and so the electrolytic imbalance results, causing heart attacks and sometimes organ failure as well. So you've got to be careful that people shouldn't drink more than a liter per hour of water in most circumstances, and even that's quite a lot for people. So just be careful that people don't overdrink on water. The reality of the situation is the majority of people don't hydrate enough, even in normal life. Forget about taking methamphetamine. But when people are fixated and maybe a dancing environment or environment where they've been taking a lot of drugs, some of them will become obsessive about it because they want to reduce the harms and end up taking way too much. And in the UK in particular, and Australia as well, we saw a number of deaths related to overhydrating for MDMA users, and occasionally for methamphetamine users, but usually just MDMA users, which has got an amphetamine component to it. So just remember that. Bottom line is, people can change, people will change. Methamphetamine is not a demon drug. It's whether it's more dangerous than another drug, it depends on the individual and depends what drug that person is taking at the time. At moderate doses, there are probably not as many harms as people would fear. Dose response is increased doses is the major danger around methamphetamine. And remember that people are taking it for a reason. And we really need to address the underlying reasons, not only the methamphetamine use. At COSUP, we're rolling out the contemplation group slowly but surely. We've had good success with it in the past, and we hope to have good success with it in the future. But we'll measure that and make sure scientifically that it's justified, although theoretically it's justified. But often there's a gap between theory and practice. Hopefully you've learned something from the session. As I say, I apologize that you've just been hearing my voice. We will post the major content onto the website and let you know as soon as it's available. Next time we will be talking about motivational interviewing, and hopefully with a guest or two. So thanks very much for joining, and I hope you have a good week further, and I hope that you find this helpful when dealing with your clients and less stressful. Remember, the number one purpose of your intervention is to help people make conscious, well-informed decisions about the how, where, when, where, what drugs to use or not use, and to use them as safely as possible. Thanks.